Do you see my screen?
No, yep, we can see it now.
Okay. All right. Well, thank you for the opportunity. It's a pleasure to speak at your meeting here, and it seems like I'm going to take a step backward here to talk about evolution of transcatheter aortic valve replacement. After all, the great talks we had, so I'm going to take a step back and review some of the data that led to where we are right now in terms of this fantastic therapy that we offer to our patients. So these are my disclosures. So as you all know, the first TAVR ever done was by Dr. Kerber in almost 21 years ago. Now was done in a young patient with cardiogenic shock and bicuspid valve. Was fantastic innovation at this time, thinking out of the box, a lot of personal effort. And this moment 21 years ago led to what is mainstream therapy right now. As you know, in 2015, the number of TAVRs done was more than the number of isolated AVRs. And then in 2018, it even crossed all surgical aortic valve replacement and becoming the most common therapy for aortic valve replacement in severe aortic stenosis patient. And it's expanding into lower population, lower risk, and there's a lot of improvement coming into TAVR in terms of design and work on leaflet technology, which we're going to briefly touch on. So as you know, we're going to focus first on aortic stenosis. I'm going to touch a little bit of, on aortic regurgitation toward the end of what data we have available. But, aortic stenosis is a disease you're all familiar with. We're talking about here, but the tri-leaflet calcific aortic stenosis. John covered the bicuspid aortic stenosis in great detail, so I'm not going to talk about that. Traditionally speaking, those patients are divided into risk groups depending on their expected risk of mortality from surgical aortic valve replacement into low risk, intermediate risk, high risk, and very high or inoperable patients. So originally, when this started, the technology came out. They started with patients who are really not candidates for surgery, and they tried to do TAVR compared to just medical therapy, and that of course showed improvement. Again, those are very, very sick patients with multiple comorbidities. So a lot of mortality, and this is probably not related. A lot of this not related to TAVR, related just to that population being very sick. And you see here both balloon expandable, self-expanding trials, the very early trials for inoperable patient, and that led to FDA approval for the device. Then we moved to the higher risk group, the high risk group, one step down toward a little bit lower risk, and they compared that to surgery, and TAVR did as good as surgery in this population. That led to approval in the high risk group, then moved to the intermediate, both for the partner trial and the core valve trials, compared TAVR to surgery. And you see that they kind of performed very similar. Now, these are early trials using early generation valves, and we'll touch on this a little bit. But when this trial was out, also the FDA here in the United States and and regulatory bodies in other countries approved TAVR for intermediate risk group. Then taking this amazing technology step forward, we start talking about low risk patients and how we're going to treat that, and that led us to the partner tree trial and the low risk trial for the self-expanding valves. Very well designed trials, like all the other trials done in this field, randomizing patients 1-to-1 between TAVR and surgery. If you look at here, they randomized about 1,000 patients for the balloon expandable valves and about 1,500 patients in the self-expanding valve. They look at the different endpoints, including the primary endpoints of all-cause mortality and disabling strokes. some secondary endpoints. Now here, this slide showing you that by the time we get to the low risk trial, we kind of moved at least 2 generations on the Edwards SAPIEN valve to their S3 valve, which is improved design, has a skirt to prevent leak, has smaller sheath sizes, and also similar improvement seen where a lot of patients got the Evolute R and Evolute Pro in these trials, which are the improved second, third generation self-expanding valves. So these trials also showed big actually separation in the curves and kind of it's not just non-inferior, maybe superior outcomes, as well as the analysis indicated for all-cause mortality, strokes, or rehospitalization for the self-expanding valve, and all-cause mortality and disabling stroke for the balloon expanding valve, and the all-cause mortality and strokes at 2 years for self-expanding valve. So that led to the conclusion that low-risk patients actually do very well with TAVR, and it might be the preferred strategy and preferred anatomy. Now, it's important to mention that this trial only included transfemoral access and excluded anybody with high-risk anatomy or needing alternative access. And now, given this outcome, that led to the FDA approval here in the United States for the low-risk group, and now we have two-year outcome, the continuous separation of the curves, and they don't cross over or anything's changed. So we still see this excellent outcome in TAVR. And this is kind of summary of these trials and how they evolved. Now we can wonder why is the low risk separation was more obvious, maybe a little bit better performance with TAVR. Now this can be attributed to multiple things, including gaining operator experience, better ways to size your valves using CT scans, newer generation valves. And if you take these back and maybe redo the intermediate risk or the high risk trial, you might see separation of the curves like you see in the low risk trial. So a lot of work has been done in this field in terms of improving and streamlining the procedure. Now, all these trials led to the revision of the ACC/HA guidelines, where they took out the risk group and focused on age, suitability for mechanical valve and anticoagulation in a younger group, and suitability for TAVR in people older than 65 to kind of recommend what treatment those patients should be receiving. Now, again, this is just the history of these valves and how they evolved in the trials, different iterations, different delivery systems. Most recent iteration of the Edwards valve is the SAPIEN Ultra with Resilia leaflet technology, which is supposed to reduce leaflet calcification, improve durability, which was launched in the second half of last year. Similar timeline seen on the Evolute family, with most recent improvement in the delivery system of the Evolute Pro Plus, adding the Evolute, leading to the Evolute Flex with improved delivery system, more flexible, which help having more predictable deployment in these patients. Now we also have portable valve approved in NSAIDs for high-risk patients, and other clinical trials ongoing to study the intermediate risk group. Now we're all familiar with these TAVRs. We touch on alternative access, so I'm just gonna keep going on. But the evolution of these procedure led to sometimes, not in the low risk group, but maybe intermediate high risk group, if alternative access needed, there are more ways to get that TAVR in. It's including transcarotid as the second most favorable access for a lot of institutions. Axillary and the apical and direct aortic really are basically going away because we know these are not great approaches and associated with a lot of complications. Now, transcable is something also being done in some institution with people with prohibitive femoral access and maybe not great carotid access. So there's different ways to get these valves delivered to where they need to be. Now, what about durability? And especially that we're going into younger and younger population. Now we have recent data of pooled analysis from multiple trials looking at the self-expanding valve compared to surgical valves, and we actually did see less pervasive prosthetic valve deterioration with the core valve compared to surgical valve, especially in the small annulus. So this is also great. So this will lead us to maybe be more comfortable treating younger patients with this technology. Now, I want to touch a little bit about patients who had surgical aortic valve placed, and now
Sorry,
these
Ahmed, just
procedures
last 1 minute,
failed.
please.
So we have good data that this procedure is very feasible, very successful, both from the VIVID registry and the registry associated with the clinical trials, maybe in the not in the mainstream randomized cohort, but the registry cohort, that the performance of valve-in-valve TAVR is good, with survival rates of more than 90 at 30 days and more than 80 in 1 year from the VIVID registry. So that led to approval of these valve-in-valve procedures in a high-risk population for high risk for redo surgery. Now, there is some issues with this, including suitability of the anatomy, risk of coronary obstruction. So there's a lot of work ongoing in terms of leaflet modification, bioprosthetic valve fracture, which is kind of beyond the scope of my talk here with the limited time.
Sorry, Ahmed,
But
we are
this is
running out
what,
of time now.
the basilica procedure. I know you guys, Dr. Hakim did a recent basilica procedure in Karachi, which was a huge step, and congratulations for that. Now, this is an example of kind of basilica, how you mitigate the risk of coronary obstruction by splitting the leaflet, and then you deploy the valve. And this is for if the surgical valve is in place in a way with low coronary is not optimized for future TAVR, which is something now surgeons are paying attention to and doing a much better job. No, TAVR is another discussion. There's a lot of data coming out about the new skirt and how we manage this and risk of coronary obstruction or future coronary access.
Okay.
So all these development and all these changes led to the talk about lifetime management of aortic stenosis, and you guys had to talk about this morning. So it's important to think the age of the patient, how suitability of anatomy for TAVR and TAVR, how we're going to minimize the number of stenotomies. So that takes a whole team to look at this, and depending on multiple things, primarily age, anatomy, suitability for valve-in-valve, ability to access their coronary, durability data as becomes more available to kind of guide, especially the younger age group, to see which treatment you're going to recommend and you feel comfortable with for your patient. Now, also,
sorry,
I'm going
Ahmed,
to touch briefly about asymptomatic patients, because there's data is going to be soon available for these patients. And we talk about patients who have severe aortic stenosis but not showing any symptoms.
Yep.
And there is clear indication
Ahmed, can you hear us?
for treatment in the guidelines in terms of there's dropping ejection fraction or abnormal exercise stress testing or rapid acceleration of gradient worsening aortic stenosis. Or critical aortic stenosis. These are kind of indications to look into. There's also some studies that looked into strain imaging and also MRI for fibrosis to kind of recommend treatment if there's an LVG.
Sorry, Ahmed, I think we have to cut you off. We have ran out of time. Sorry. So we have a live case ready from Oklahoma Heart Center where Dr. Naeem Tahir Kheli is waiting for us. So we'll have to delay the Q&A session till after that. Please feel free to stay back, both you and Sahil. I would just like the audience to give a round of applause for both the presenters, because we're going to go to live case. Thank you very much. It was very comprehensive, and we understand that it was the time was really short. So, Dr. Naeem Tahir Kheli, can you hear us?